Can you all hear me? Okay. So sorry about any technical issues that we've been having so far. But I do want to thank Steve and everybody else here for having me today. Very excited to represent the Louisville Health Department and talk to you guys about our quick response team. So I'll basically give you a brief overview of how the quick response teams began in America. And then how they moved into Kentucky, and then more specifically, how we go over it in Louisville. So my name is Cillian Browne. Thanks, Steve. I do get my name butchered quite often, but I'm used to it by now, so I wouldn't have been offended at all. I've been a health program analyst with Louisville Public Health and Wellness for a little over a year now, primarily with the quick response team. With some other duties throughout the week and the months, reaching into other areas of the health department. So the quick response team was first created in Coleraine Township, Ohio. We got any Ohio natives here? Yeah, right there.
That's my neighbor.
It is.
I live right there.
Thank them for us. It was a collaboration effort between Coleraine Police, Fire, EMS, and Addiction Services, primarily to reduce the number of opioid overdoses in the community. And so far to date, the Coleraine Township has responded to over 250 overdose follow-up incidents, with an 85% rate of follow-ups being connected to treatment services. So, they saw a drastic increase in opioid overdoses over the last, I'd say about 6 to 8 years prior to them setting it up. And they just wanted to take action, do something about it. And so that kind of set the wheel in motion for other towns to see what they did, and then tweak it and adjust it to whatever way they wanted to implement it into their town. The primary quick response team model is based around providing a wellness check to community members after they experience an overdose. Ideally, this is done within a short period of time of them having experienced the overdose. So I've seen anything from 24 to 72 hours up to 5 to 7 days. I know in Louisville, we got to them so quickly that sometimes they weren't getting home from the hospital, or if they weren't in any place to have a conversation with us. So we decided to rein it back and just kind of give them that 48 to 72 hour sweet spot where we were able to have that conversation with them. In most cities and counties, the visit is carried out by a police officer and a clinician. In our local health department, we're led simply by a team of peer support. So there's myself and 3 other people who all have lived experience in recovery. And we find it's just a different avenue to approach somebody with. We're able to strike up a connection that's based very heavily on relatability from past experiences. So it opens up a pretty deep and meaningful conversation most of the time. So overall, QRTs were created to reduce overdose fatalities and to provide community members to resources that they may or may not already know about. Here's a little map to show you where quick response teams are in Kentucky. So the first quick response team in Coleraine came about in 2015. By 2017, it had reached Kentucky. And today we have over 20 counties that boast a very promising quick response team. Just got an email today that there are 2 more counties that are looking to expand and mimic the system that we're operating. So it's a growing program, like the Purple Star you were talking about. It's a deep need in our communities, and one that's greatly appreciated by a lot of people, and I'm very grateful that I get to do it. So like I said, we're operated by the Louisville Health Department, but not all of them are in Kentucky. A lot of them are operated out of like recovery centers or local authorities as well. And this is the rest of the places that we have them in Kentucky. If you, if any of these are your county and you need any details, you can take it down here, or I'll be more than happy to forward this presentation on to anybody who wants it. So the quick response teams in Kentucky are core funded. I'm sure a lot of you are aware. CORE is the Kentucky Opioid Response Effort. And they seek to expand and sustain comprehensive and equitable recovery-oriented system of care to end the opioid epidemic that has reached into our Kentucky communities. It is SAMHSA funded and supports evidence-based prevention, treatment, and recovery. Core funded partners and services model policies and practices grounded in best practice and compassion. I can personally say from my experience, I'm very happy and grateful to work with CORE. They're at the state level, and it's definitely filled with a ton of people who just care about the work they're doing. And I think that's what it comes down to, you know. A lot of people could get a job in this field, but I mean, you have to care about what you're doing, or else the fear is that you won't make an impact. So in July 2021, we at the health department were able to launch our quick response team. But its first initiation was a collaboration through Louisville Metro Police Department and Centerstone Recovery, Behavioral Health Services. This came at, like, it couldn't have come at a worse time, to be honest with you. The racial uprising in Kentucky, in Louisville specifically, paired with the COVID pandemic, just stretched both organizations extraordinarily thin, and they just had to put it on the back burner. And then luckily somebody was able to pick it up and continue it on, and we were that somebody. And we've been able to, you know, hit the ground running pretty hard. We're out there every day trying to connect with as many people as we can. So yeah, July 21, we were able to pick up the program and respond to our residents. And the way it works for us is that there's a Kentucky revised statute, and I'm pretty sure it's how it works in the rest of the quick response teams. I can't imagine it would be too much different. But this KRS allows emergency services like EMS and local authorities, police departments, fire organizations, and things like that, to pass on information to the health department, as long as it's pertaining to an overdose and as long as there's Narcan being used. So a lot of what we get when we're in the field is questions of, like, how did you get my information? Is this public knowledge? It does initially instill a lot of fear and a lot of fear in people. And so, you know, we just explain to them, we lead with compassion, honesty, open-mindedness, and a judgment-free zone. And we just talk to them like the normal individuals, human beings that they are. And that's how we spark up that connection. But there is a lot of questions of how do we get their information. So we're grateful for that. Part of one of the projects I'm working on right now is to expand our reach so we can, like, you know, cast a wider net out into the community and reach more people that are overdosing that we're not getting the data back on. So I'm trying to connect with fire departments, other ambulance services, police departments. And it's a process. You know, they have a lot of information and data that they need to make sure that they're using correctly. So they want to make sure that they're allowed to share it with us at the health department. So it's a lot of back and forth, and it's a slow process, but, you know, one we're willing to take, just to reach more people. So like I said, we work with partnerships with Metro EMS, local authorities, hospitals. One of the reasons I'm here is because of Mark from U of L, who invited me here. He connected me to Steve. We get to work with partners like them, and they're extraordinarily open-minded and open-hearted with this program, and they're willing to jump through a lot of hoops and break a lot of boundaries in order to make our job easier, and then hopefully therefore we make their job easier. one of the more recent things that we've pushed through is people who go to the hospital for an overdose that did not arrive in an ambulance. So let's say I overdose and Emily King is with me and she throws me in the back of her car and she just drives me to the hospital. She doesn't want to get in trouble. She doesn't want me to get in trouble. It's a small number, but it's a number nonetheless. So I reached out to two pretty big hospitals in town, and they loved it. They were more than willing to go through the process of connecting with their legal team and me connecting with my legal team and making sure that we're following all guidelines and boundaries. And inevitably, if that does happen, if and when it does happen, that they will be able to share that information with us, and then we can go and visit that person and start that conversation. It's a lot of talking. So since we began, am I doing okay? This is nervous. I'm very nervous doing this. I don't do this at all. So since we began over 16 months ago, we've gotten over 2,500 referrals. So it just doesn't stop. We see ebbs and flows. There's not really any consistency to it. Like sometimes we think it might be the weather that is deterring somebody from using or increasing their chances of using. But we don't know. So of those 2,500 people, we've been able to reach over 300 direct patients, over 410 family members. We've given out over 250 units of Narcan, and we've referred over 53 people to treatment. You know, it's really difficult, and it's strange to like tell you those numbers. It seems very just cut and dry when I tell you these numbers, but you know, those conversations that we had in the field are very difficult, very hard to navigate. You know, you're walking into people's homes, they're not expecting us. We show up on their porch and they can either tell us to leave, whatever way they choose to tell us, or we have that conversation with them. And there's a lot of hugs and tears and arguing and back and forth and trying to help them with things. And, you know, they overdose, but they need help with their LG&E bill, or it's a lot, man. But it's worth it. I love it. I wouldn't change it for the world. Well, actually I would. If in an ideal world, I wouldn't even be doing this job. So, you know, with our team, we utilize a harm reduction approach. I think that really helps, leading with peers who've been through it. I hear a lot of success stories in other quick response teams, and they lead with police officers. So I don't think there's any right or wrong way. This is just the way we're doing it. And it works really well. So like I said, a harm reduction approach. So in doing so, we always try to meet people where they're at, but not leave them where they're at. So, you know, like I said before, compassion, honesty, open-mindedness. We're not going to judge them. We say sentences like, I've been where you are before. You're being too hard on yourself. Give yourself some credit. You know, those are sentences that I heard years ago that broke me down and helped me open up. And they still carry a lot of weight today when we talk to people in the community. We're a peer support led team, and we're able to compassionately connect and empathize with people that we meet, having felt those similar lows and pains. We're also the government, so at the end of the day, regardless of what department we're in, regardless of what program we're working, we are a government entity. And the fact of the matter is, not all people trust the government, and that's okay. They have plenty of reason not to. So when we lead with compassion and honesty, and we talk with people, and you know, we're able to look at them face to face, and we can put our arm on their shoulder and shake their hand, it does help to break down that trust barrier and build relationships with people. It's very hard to do all of this with one meet, with one interaction, and we're stretched pretty thin. So to follow up with people would be great. We try to do it as often as we can. We exchange phone numbers. I stay in touch with people as much as I can, but it's tough to maintain that connection. Like, this isn't in my notes. At the end of the day, it's hard, man, because a lot of times they think they want help or they think they need the help, but this is something to go through. You got to really want it, and so that's what I mean when we say that we meet people where they're at, but we don't leave them where they're at. So if I meet somebody and they're not ready, that's okay. I need to constantly be there we need to constantly be there until they are ready. I have somebody today going to treatment. I just got off the phone with her before I came in here, and she's terrified. And she's been to this treatment facility twice in the last 2 weeks, and both times she got to the door and she ran away. And so it's hard. A lot of people have given up on them. They're tired. Their family members, they've watched them go through this their entire life. Sometimes they're pissed off. And so we need to constantly remind ourselves that we need to be there for them no matter what they need. And if we go out with syringes and harm reduction tools like that, and if that's all they want and they're not ready to stop using drugs, that's fine. I got clean syringes in the car. I'll make sure you have enough for the next week, and then I'll come back and see you again until they're ready. And that's how it works, They meet me and they don't want to talk to me. They don't want to deal with me. Unfortunately, a lot of times they appear on our list again. So when I go and see them again, they're like, "Oh, hey, I remember you. What was that thing you talked to me about?" And I was like, "Oh, Narcan. You want me to tell you about it again?" And they're like, yeah, I think I'll take some of them. And that's how we start the process, and that's how we start the conversation. It sucks that we have to do it, but we have to do it, We come across a lot of challenges. When EMS report back to us, we have a lot of people who don't give an apartment number. It makes it very hard to visit these people. A lot of times they got picked up on a street corner. So, EMS are doing the best they can, and we're incredibly grateful for what they do. And they're not wrong. They did pick them up on the corner of Brook and Broadway or wherever it may be. So obviously we can't go back there. The chances of us finding that person are very slim. There's also a lot of confidentiality with our job. So, if somebody appears on our list, and I know that they're unhoused, and I know that they stay at encampments, I can't really reach out to a lot of people I know in the community and be like, "Hey, have you seen Cillian Browne lately?" Because they're gonna know, well, if you're looking for Cillian Browne, then Cillian Browne overdosed recently. And so we really try to uphold that confidentiality, like to an extreme degree, because once it gets out that one or two people's information has been released, they're just gonna shut off from us. They're going to go back to not trusting us and not thinking we're a safe place. So that's very important for us. Sometimes we don't get phone numbers. Like I said, we have a lot of people who don't trust us, and that's okay. We continue to be there for them. We see a ton of stigma around people who use substances, a lot of shame and guilt and embarrassment. They, like myself, put very large expectations on themselves, and when they don't meet them, they're very hard on themselves. I think we all do that in some ways, but stigma can block somebody to go and get help, to go and get treatment. They're afraid of what people are going to think of them. They're afraid I was talking to somebody last week who simply would not open up to me about the fact that they overdosed, and I respected that. That's fine. And then it turns out later on in our conversation that they were just afraid that CPS were going to get called and take their kids away, which is a terrible place to be in. So, you know, look, I don't think I would do it any differently if I was in their position, to be honest with you. They're in between a rock and a hard place. And like I said, the first time we meet them, it's very rare that they open up to us, especially when there's kids involved. So we always approach with judgment-free compassion and empathy. And once we let them know that we've been through it before, it does break down some walls. You can see them relax a little bit. Yeah. Internally, we do struggle, I mentioned before. We do have a small number of staff for a very big county. And we're currently working with partners in Louisville to take on some more peer supports who can go out with us in the field once or twice a week. And so essentially that would expand our team and enable us to send 2 teams out in a day instead of just 1. I'd love to be able to send 1 out for the people who are on our list and then send another out for the people who were on our list last week and follow up with them. That second interaction is key. We see our journey up until now has been a 2-directional process, which is beautiful. So we go out and we provide information to people. Cillian overdoses and we tell him where he can get clean syringes, where he can get treatment if he wants to get like mental health services. We tell him as much as we can, and then we also get feedback from him, the type of drugs he's using, how he's using them, how often he's using them, where he gets them from, a little bit about his history. We find out a lot about people, and it's good. It's good information that we get. So like that conversation, that outreach also, it creates community engagement, and it sparks a conversation, and then hopefully we're able to help that spark turn into like a fire of change, basically. Yeah, they just have to be willing, and we just got to continue to be there for them. We see a lot of people who don't need harm reduction services like needle exchanges, because they don't use needles, but they do still use drugs. So it's great getting face time with them. And, you know, we tell them about syringe exchange and they're like, no, I don't need that. And I get it, I understand it. But they do use drugs, like either orally or smoking or whatever way they want to ingest it. And they're still at risk of an overdose. In fact, I would say, we see more people who don't use needles. We actually see a lot of people who thought they were taking one thing, and it turned out to be like a counterfeit pill, or Xanax, Roxy's, Perk 30s, whatever it may be. A lot of people are just out on a Saturday night thinking they're hanging out with their friends, and someone's like, hey, do you want to go into the bathroom and do this? So we do see a lot of people who say they don't regularly use drugs. Yeah. So this is a map of Jefferson County. As you can see on the left is the heavier hit side. That's where we spend most of our time. And these are predominantly low income neighborhoods with a higher crime rate, and therefore more prone to substance use. Fatal overdoses by drug type within Jefferson County from 2017 to 21. there's a big gap. There's a big increase from 19 to 20. And then we can see the same again with opioid involved fatal overdoses. Again, 19 to 20, a very big jump. These are overdose runs by EMS from 15 to 21. So like I said, they're incredibly busy in Jefferson County. We partner with a lot of people. It makes our jobs easier and more effective, and it makes the partners' jobs hopefully easier and more effective. My favorite thing to do is take a tour of a treatment facility. So I know I did it with Emily over at Center for Behavioral Health, and it's not called that anymore. It's not. Bluegrass
Behavioral Health Group.
Right, I apologize. But what this does is it allows me to meet, in this case, Emily face to face. And when I go out in the field and somebody wants to do a specific type of treatment that they have in mind and they don't know where to start, and they go online and they Google it and they call people and they're waiting on hold, essentially they just give up. So I'm able to I'm able to let them know that I know Emily. And I'm like, hey, I got a contact over at this place. They're good people, they take care of you. I've seen it, I've been in there. It adds a little bit more of a personal touch rather than just giving them a phone number to an office where they're going to be on hold and they're going to have to, when you're on hold and you got to say what they want. For some reason, they don't ever understand me. But I have my thoughts on why that is. I talked to a lot of people who just said, look, man, I tried to get into this, I tried to get into that program, and they messed me around and I had to wait online, or I had to wait in the waiting room for 2 or 3 hours. And again, if I had to do that, I'd probably just go back out and do drugs, because I know I can call my guy and he can get it from me immediately. We have rigorously partnered, developed partnerships in Louisville with hospitals, emergency services, treatment facilities, behavioral health services, and community centers. We try to foster genuine, compassionate relationships with as many community partners as we can, so we can help each other, help the community, and help individuals as well. This foundation creates a two-way trust system where 2 or more parties can work together with similar goals and outcomes, again, to help our residents and help the community. And like I said, we take tours of treatment facilities, we do Narcan trainings in the community, we table events, and we bring education to places like schools, and Louisville Metro Department of Corrections. We brought in a string of Narcan trainings in there. We got Narcan in the dorms that have since been used to reverse several overdoses within the jail. We do come across a lot of barriers, 2 of which are transportation and housing. So if somebody is in the community and they want to go to treatment, whether they know about it or not, a lot of time they don't have a way to get to that treatment facility. If it's not their first time around, they may have had a bad experience with one place, so they don't want to try that, or they may have had a bad experience with one type of treatment and they don't want to do that again, so they want to do something else. The top of our list is people who want to do methadone treatment. To begin methadone treatment, you have to appear daily. And for a lot of people, they don't have consistent transportation, and it's just hard for them. And so they try it, and it's not their fault. It's not the methadone treatment's fault. They just are not able to make it there, so they fall off, and they struggle real hard. Many people, we see a lot of people in terrible, unhygienic, unsafe living conditions. But unfortunately, they face huge challenges, because if you want to get new housing, 9 times out of 10, you have to be not using a substance. So as soon as they find out that you're using a substance, you just get taken off the list. So it's tough. We have resources. Like I said, we connect with a lot of people in town. There's a lot of card exchanges. And that's how I get to know people. And I shoot them an email. I'm like, hey, it was really nice meeting you today. Like, this is my email. Now you have mine. I have yours. And then I just probably annoyed them quite often by sending a flood of people. I'm like, call Rebecca, call Rebecca, call Rebecca. She can help you with that. But transportation and housing is a big one. There's a recent development of a local non-profit called Seeds of New Leaf, and they have a rolling recovery van to where they will transport community members to and from wherever they want to go, regardless of if it is to their treatment facility or not. So it is starting to change a little bit, and hopefully it will continue to change. And I think that's all I have. Thank you. Any questions?
Something you may not be able to answer. I'm Marcy with Mental Health America of Kentucky. We have paramedicine in Lexington, which is a very similar model.
Okay.
They do a QRT response as well.
Yeah.
But they also do it for other high incident calls. Is that something that you think Louisville would ever consider?
Because because like that's how it started in Coleraine.
Yeah.
So they responded to overdoses, but they also responded to other things as well. Something we are developing in Louisville, not the health department, but it's more from Louisville Metro Police Department, is the deflection unit. So if I call 911, and I have a contact for him as well, I can give it to you if you want. If I call 911, and they can kind of figure out if the level of importance it is. A lot of time, if it's a mental health crisis, they can pass it off to the deflection unit, and they can send out trained, but we're not trained in that, so we can only respond to overdoses. Yes.
Started to choke, sorry. You were talking a little bit earlier on about the sweet spot of time that you go out and you talk. And I was just wondering if you could say a little bit more about that. I've heard both sides that sometimes you have to get through fast, and then sometimes you can a little bit longer to drop your numbers. But it sounds like you've got some experience in both of those. So it's like you're a little bit more.
Yeah, thank you. So I still think we get to people pretty quickly, but we did find out that you can get to people too quickly. And a lot of the time the family member would answer and we'd ask for, is Cillian there? And they're like, Cillian's still at the hospital. And so we decided to pull it back a little bit. So we were getting to that person, if they overdose, what day is today? Wednesday. We were visiting them by Thursday. And we were like, okay, we got to pull this back a little bit. We're wasting our time and resources, where if we could give it an extra little bit of time. And so we pulled it back from like within 24 hours to within 48 to 72 hours. There have been a few cases where we weren't able to get to them within 72 hours, and we would get to them within, 96 next? I can't do my 24 times 24 math. But we would get to them within, like, before the 7 days is up. And that conversation went well as well. I do think we've cut it off at about 2 months, even for follow-ups. We found that we followed up with people months and months later, and they weren't really open to talking with us. I think maybe in their mind they were like, hey, I'm good, I don't need you coming around here. We used to get a lot more phone numbers and we'd be able to call them. And so, you know, a lot of the time people aren't home, they're working during the day. So we leave a door hanger with my phone number on it. And then I had 2 missed calls as I was sitting in the back there. So I'll call them back and it'll be, the conversation will be like, hey, I had a door hanger. What is this about? And it's a very discreet door hanger. So we don't want to mention quick response team because anybody can Google it and be like, oh, that's what this person's here for. So it either means this person's here for my overdose, or more often it's like, oh, somebody in this building must have overdosed. So again, we want to protect their confidentiality. I'm getting off track from your question, but we do want to protect their confidentiality and not out anybody. So we have a discreet, hey, Louisville Public Health and Wellness just called. And so I'll get phone calls, but like, is this about COVID? Is this about the mold situation? Is this about CPS? And again, I have to navigate that very, very cautiously. And I'd be like, well, who am I talking to? And you're talking to Cillian Browne. And I'm like, well, and then I have to find out the address they're calling from. And 9 times out of 10, I got to whip my laptop out. So I'm doing this. And then I find out the address and I'm like, oh, actually, Kathy, we were calling to speak with Cillian. And then I get a lot of like, well, I'm his mother. What can you tell me? And obviously we're not allowed to share that information with Kathy, only Cillian. So again, with honesty and compassion, we've tried before to dance around that question and it didn't go well. So with honesty and compassion, we just say like, listen, I appreciate your concern for your son or child or whoever it may be. But because of HIPAA laws, I'm only allowed to talk to Cillian. So yes, there is a period of time that we found is too short, and there's definitely a period of time that we think it's too much time has passed. Yeah.
Is there an ideal like hour range after?
We don't go out too late in the evening. We generally work Monday to Friday from any time between 9 and 4 is when we operate.
What about weekends?
We used to do Saturdays, but they became too sporadic and too inconsistent. I found Saturdays to be like a wild card. But more often than not, we didn't connect with people on Saturdays either. There seems to be a little bit more structure from Monday to Friday. Yeah. All right. Well, thank you again so much, guys. I really appreciate it. What's that? I have a question up here.
Yeah.
Oh, I'm sorry.
I was just gonna ask, considering stigma and, the distrust of police in Louisville because of everything that's been happening, and laws regarding substances, is, having police show up inhibiting those conversations?
You know, like I'm torn between that question. I think a lot of it comes down to the individual themselves. It really depends. Like I know a ton of people who would say yes and no to that answer. We used to have a homeless outreach team in Louisville that was led by 2 police officers in town. And they went to all the encampments. And so it was 2 police officers and then just a ton of people. And they would go out with syringes and food and clothing and all sorts. And so a lot of people have a certain view on police officers. And I know those police officers for sure led with their heart and, you know, they love the job they do. Unfortunately, that program got pulled. I think, you know, during the time of the racial uprising, more often than not, it might not have looked good. I mean, I don't do anything wrong anymore, but if I see a cop coming up to my house, I'm like mentally checking, what did I do? You know what I mean? Yeah. It never looks good. And there are a lot of pros to leading with police officers. Jefferson Town is a subdivision in Louisville, and they operate the REACH program, which is with 1 or 2 social workers and two social workers and the police, and they have fantastic results. The police are able to tap into a database that I'm not able to tap into. They're able to check records. And so one of the social workers explained the situation to me, and I was like, oh my God, man, I wish we were able to do that, but we can't because we're the health department, you know? I think the situation was like they were looking for person A and they went to a house, and then they were able to like research that person in their criminal database. I don't know if I'm using the correct terms here. And they were able to find out where that person hung out, and then they went and found them and they got that person in treatment. You know what I mean? So it was wonderful.
CIC forms really helpful for women of mental health and other instances.
Yeah. Yeah. So, I mean, it really depends. I see a lot of people who are pro police officers and a lot of people who are against it. Yeah. But in Coleraine and other townships and other places that do QRT, they do lead with that and they have great success. I think part of it might come down to the city itself. So yeah, thanks. Did I answer your question?
Yeah.
Okay, thank you.
Thank you.
Yeah.
Thank you, Mr. Brown.
Thank you.